Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. My email is sreeklpm@gmail.com. Today we are going to talk about one of the most fascinating topics of neurology, the supranuclear control of gaze. The supranuclear eye movements today we are going to discuss. Very fascinating but challenging too. The supranuclear control of gaze. The supranuclear mechanisms that control gaze are designed to ensure that the fovea maintains fixation on the object of interest despite movements of the object, the eyes or the head. So basically eye movements we have three types. The supranuclear eye control, that is the pathways above the third, fourth and sixth cranial nerve nuclei, what we call it as supranuclear pathways. Then we have the internuclear pathways connecting the third, fourth with sixth, known as the medial longitudinal fascicles. Then we have the infranuclear pathways, that is the third, fourth, sixth cranial nerves. So when we approach eye movement disorder, we should see whether it is supranuclear or internuclear or infranuclear. Supranuclear means the pathways above the third, fourth, sixth cranial nerve nuclei, like saccadic pathways and PERSUIT pathways. The internuclear pathway is between the third, fourth and sixth, the connecting pathway, which is medial longitudinal fascicles. And finally we have the third, fourth, sixth cranial nerve nuclei, third, fourth, sixth cranial nerves per se getting involved, what we call it as an infranuclear pathway. Very interesting and very important. For example, why the third and fourth, sixth cranial nerve should be interconnected, otherwise we will not have a conjugate gaze. For example, if I want to look to the right, I have to use my right lateral rectus supplied by sixth cranial nerve, but medial rectus supplied by the third cranial nerve. So I have to use the third on one side and sixth on the other side together. Then only I can follow a particular object or a reflex fast movement to the opposite side. Third on one side, sixth on the opposite side. How are these well coordinated? Third on one side, sixth cranial nerve on the opposite side. It is because of the medial longitudinal fascicles. Because of this medial longitudinal fascicles connecting the third, fourth, sixth cranial nerves, we can have various permutations and combinations of movements. I can look upwards, both superior recti, downwards, both medial recti, or on one side, right lateral rectus, left medial rectus. So I can use various combinations of movements because the third, fourth and sixth cranial nerves are interconnected through MLF. So the supranuclear mechanisms that control gaze are designed to ensure that the fovea maintain fixation on the object of interest despite movements of the objects, the eyes or the head. So basically we have two important supranuclear pathways causing saccades, and second is the PERSUIT. A saccade, that is a fast movements. Someone knocks at the door, I want to look to the right. These fast movements, saccade jerk, is a quick small amplitude eye movement to acquire a target. Saccades are designed rapidly to shift the gaze to the target. Rapid movement. Second is the PERSUIT movement. These are the following movements. For example, I want to watch a nice shuttlecock match between some two international stars. So I watch the shuttlecock moving from one side to the other. These are known as the following movements or the PERSUIT movements. The PERSUIT movements are slow, smooth eye movements to track a target once acquired. PERSUIT movements are designed to maintain foveation of a moving target. The gaze centers. We have two important gaze centers. One for all horizontal eye movements, it is known as horizontal gaze centers. One for all vertical eye movements, which are known as a vertical gaze center. The sixth nerve nucleus and the PPRF, that is the para-median pontine reticular formation, is the final pathway controlling all horizontal eye movements. Therefore, the center for all horizontal eye movements is pons. Very important. The center for all horizontal eye movement, be it saccades or PERSUIT, the center is pons. The center for all horizontal eye movements is pons. The vertical gaze centers lies in the midbrain. Therefore, the center for all vertical eye movements, whether up gaze or down gaze, it is the midbrain. So, very important concepts. The center for all horizontal eye movements is pons. The center for all vertical eye movements is the midbrain. Yeah, these are the fascinating concepts of saccadic and PERSUIT pathways. So here you can see the PERSUIT pathway encircled in blue color and the saccadic pathway encircled in the red color. Very important is that the PERSUIT pathway, you have double crossing. You can see there from the parieto-temporal occipital position on the right side, it comes to the DLPN, crosses to the cerebellum on the opposite side, goes to the vestibular nucleus, back to the 6th nerve nucleus and PPRF. So the PERSUIT movement, because of this double crossing, PERSUIT movements control the slow falling PERSUIT movements, the pathways on the same side of the lobe. So the right parieto-temporal occipital lobe controls the PERSUIT movements to the same side because of this double crossing. It goes to the cerebellum on the opposite side and then comes to the PPRF. Very important point. Whereas saccadic pathway control the eye movements to the opposite side. So front eye fields area number 8 goes to the PPRF on the opposite side. PPRF connects 6th nerve on the same side and medial rectus through MLF. So when the left PPRF is stimulated, the eyes move to the opposite side. Saccadic pathway. So very important point, saccadic pathway, the movement is controlled by the opposite lobe, that is the fast movement, whereas the falling PERSUIT movements, the movement is controlled by the same side of the lobe. And another important point is that PPRF is responsible for the gaze, horizontal gaze. We have the 6th nerve nuclei which goes to the, so we have the 6th nerve nuclei coming up from the PPRF which is responsible for the gaze. 6th nerve nuclei complex, it has got a fiber going to the lateral rectus, so LR6 lateral rectus supplied by 6th nerve, but it has got an internuclear complex also in 6th nerve nuclear complex which goes to the MLF and supplies the 3rd nerve on the opposite side. So when the 6th nerve nuclei, not nucleus, when the 6th nerve nuclear complex is involved, you have the gaze palsy. So 6th nerve nuclei complex supplies the lateral rectus on the same side and the 3rd nerve medial rectus to the MLF on the opposite side. So when the PPRF is stimulated, the eyes are moved to the same side. For example, when the right PPRF is stimulated, the eyes move to the right side. Right lateral rectus to the 6th nerve and the medial rectus on the opposite side to the MLF. So 3 important points we learn from these pathways. 1, the saccadic pathway, that is the fast eye movement, is to the opposite side because the saccadic movements are controlled by the frontal eye fields area number 8 on the opposite side. It crosses over and goes to the PPRF. Whereas the PERSUIT or slow eye movements, falling movements, are controlled by the pathways originated from the same side of the lobe because of double crossing. And then the 6th nerve nuclear complex, the pathways coming from the PPRF are responsible for horizontal gaze. 6th nerve nucleus and lateral rectus and the 6th nuclear internuclear complex going to the medial rectus through the MLF on the opposite side. So 6th nerve nucleus controls the eye movement towards the same side, horizontal gaze. So when the 6th nerve nucleus, PPRF and the 6th nerve nucleus complex is stimulated, the right lateral rectus and the left medial rectus through MLF are stimulated. So the horizontal gaze is to the same side. Right, as I said, the frontal eye fields controls horizontal conjugate gaze to the opposite side. You can see the right frontal eye fields, the fibers descend and decussate en route to the PPRF and goes to the PPRF, which controls the right lateral rectus and the left medial rectus to the MLF on the opposite side. So this is the very important pathway, saccadic pathway, the center being the PPRF and the 6th nuclear complex. Frontal eye fields also, not only to the PPRF, the saccadic pathway, it also sends impulses to the superior colliculus pathways. They are also likely involved in reflex saccades. So we see eye movement abnormalities in Parkinson's or other brainstem structures. It is because the saccadic pathway not only goes directly to the PPRF from the frontal eye fields area number 8, it also goes to the midbrain structures like superior colliculus pathway, and therefore they are involved in reflex pathways. Signals from the PPRF activate both medial neuron 6 and interneurons 3rd and adjacent 6th nerve nucleus. So what happens is that the 6th motor nucleus activate the ipsilateral lateral rectus, whereas the interneurons simultaneously send impulses up to the MLF, which decussates and runs to the medial rectus subnucleus of the contralateral oculomotor nuclear complex in the midbrain to activate the medial rectus. So the ipsilateral lateral rectus and the contralateral medial rectus then contract synchronously to produce horizontal gaze. Not only the, as I said, the saccadic pathway coming from the frontal eye fields area number 8 going to the PPRF, they are not the only pathways. there are the pathways from the frontal eye fields area number 8 goes to the other midbrain structures, midbrain structures which like basal ganglia, and therefore in Parkinson's also we have eye movement disorders. So another system involved in the saccadic saccades work to the basal ganglia. Collaterals from the frontal eye fields area number 8 go to the head of the caudate putamen, which sends fibers to the ipsilateral substantia nigra. Neurons in the pars reticulator project to the superior colliculus, which then projects to the PPRF. Disturbances in this system may explain some of the abnormalities of the ocular motor control that occurs in the basal ganglia disorders, particularly Parkinson's disease. So you can see here the frontal eye fields area number 8 not only goes to the PPRF directly, but also sends impulses to the superior colliculus and to the basal ganglia, and therefore Parkinson's disease is also associated with eye movement abnormalities. Yeah, PERSUIT movement. See, it is here the movement is encircled in blue color. So it comes from the example, we take it right. PERSUIT movement from ipsilateral PTO to the PPRF, because double crossing decussation. So it comes from the right PTO, goes to the DLPN, crosses over to the opposite side cerebellum, goes to the vestibular nucleus, comes back to the 6th nuclear complex, 6th nerve, and then supplies the 6th and the 3rd nerve. So because of this double crossing, the PERSUIT pathways, the movement is controlled on the same side of the lobe. The smooth PERSUIT system originates ipsilateral in the region of the parieto-temporal occipital junction and functions to maintain foveation of a moving target, and it is from the same side, ipsilateral lobe. The system then double decussates. The dorsolateral pontine nuclei projects to the contralateral cerebellum. Signals from the cerebellum then activate the medial vestibular nuclei, which in turn project to the contralateral PPRF. The PPRF then coordinates horizontal PERSUIT movements. So because of this double decussation, PERSUIT movements control the movements on the same side, arising from the same side of the lobe. The smooth PERSUIT to the right is controlled by the right occipital region. Right. Another interesting topic is the optokinetic nystagmus. Optokinetic nystagmus is a PERSUIT movement followed by a corrective saccade. PERSUIT movement followed by a corrective saccade. For example, we will see on the right side, the smooth PERSUIT to the right is controlled by the right occipital region. So the example of optokinetic nystagmus is, for example, if we sit near the train seat, we see the scenery going by. So we follow the scene, it goes and then it goes out of our vision. Then there is a corrective saccade, and we catch up with another object. We follow that object as we are going in the train. It goes, the PERSUIT movement, it goes out of vision. Then there is a corrective saccade to catch up another object. This is known as optokinetic nystagmus. Keep following PERSUIT, keep following PERSUIT, reflex saccade. This can be tested at the bedside by giving a drum, black and white stripes, rotate it. The patient keeps following it, PERSUIT movement, then corrective saccade, PERSUIT movement, a corrective saccade. So the quick refix, the smooth PERSUIT to the right is controlled by the right occipital region. The quick refixation saccades back to the left are mediated by the right frontal eye fields area number 8. So the process of following a series of moving objects as in the optokinetic nystagmus or railroad nystagmus all accomplished in the same cerebral hemispheres. So this has got important implications. For example, if a person says that he is blind, is acting, it is a pseudo blindness or hysterical blindness, put a rotating drum with black and white stripes in front of him. Though he is pretending to be blind, is actually seeing the black and white stripes moving, so he'll get optokinetic nystagmus. So the presence of optokinetic nystagmus rules out blindness, another important point. And optokinetic nystagmus can get affected in the lesions of the parieto-occipital cortex. For example, if there's a tumor or abscess in the parietal lobe also, the PERSUIT movement can get affected. So these are all the important implications of the optokinetic nystagmus and the usefulness of the optokinetic nystagmus. Yeah. Next, we'll go to the vestibulo-ocular reflex or oculocephalic reflex and the doll's eye movement. For example, if I need to follow an object, if I'm turning my head to the right and keep following my object, when I turn my head to the right, my eye should move to the left. Then only I can concentrate on the object which I'm supposed to focus on. Suppose if when I turn my head also to one side, my eye also move to the same side, I'll not be able to see the object and the object appears blurred. So nature has given a wonderful mechanism known as vestibulo-ocular reflex or doll's eye movement. So when I turn my head to one side, for example, on the right side, the PPRF on the right side gets, when I turn my head to the right side, the vestibular complex on the right side gets stimulated. It goes and connects to the PPRF on the opposite side. So eyes moves to the opposite side. So I can stimulate my vestibular apparatus either by turning the head to one side or by pouring warm water. So when I turn my head to one side, I'm stimulating the vestibular apparatus. This can be stimulated also by pouring the warm water. So when I turn my head to the right side, the right vestibular complex gets stimulated. So it goes and connects to the PPRF on the left side. So eyes moves to the left side, and the FEF on the left side, now frontal eye fields area number 8, pushes it back to the normal position. So there will be corrective nystagmus. So when you put warm water, you stimulate the PPRF on the opposite side. So eyes move like this. So this is known as the oculocephalic reflex. We always talk it in terms of the correcting nystagmus. So when you put warm water, cold water, opposite, warm water, same side. So these are the mechanisms. You can see here the vestibular apparatus. 8th cranial, now when it gets stimulated, it goes and connects the PPRF. So the eyes goes to the opposite side. The corrective nystagmus by frontal eye fields on the same side. So it moves the eyes back. So easy to remember, cause cold opposite, warm same. So when you put warm water on the right side, it goes and stimulates the PPRF on the opposite side. So eyes move to the opposite side, but left frontal eye fields, now it pushes the eyes to the same side of the stimulation. So when you put warm water, the nystagmus is to the same side. When you put cold water, the nystagmus is towards the opposite side. COWS. So vestibular ocular reflex produces conjugate movements of equal amplitude but in the opposite direction to compensate for head movements in order to maintain foveation during motion of the head. Yeah, these are all about the horizontal gaze. Now we'll talk about the vertical gaze pathways. The pathways controlling up gaze and down gaze course in the region of the rostral midbrain, pretectum and the posterior commissure. So pathways for the control of vertical eye movements are in the midbrain. The pathways controlling the horizontal gaze are in the pons. Very important, vertical gaze we have up gaze and down gaze. Projections for up gaze cross to the commissure before descending to innervate the third nerve nucleus, while those for the down gaze may travel directly to the third nerve, thus accounting for the frequency of selective up gaze palsies. The up gaze fibers cross over to the opposite side and then descend, whereas down gaze fibers descend straight away. So any lesion impinging on the top of the midbrain, like a lesion on the posterior commissure, pineal gland tumor, Perinaut syndrome, it affects the crossing up gaze fibers but not the descending fibers, so they'll have up gaze palsies. So we frequently see up gaze palsies because when there's any involvement on the top of the midbrain, the crossing up gaze fibers get affected but not the down gaze fibers which descend ipsilaterally, and therefore we frequently see up gaze palsy, example Perinaut syndrome. The vertical gaze equivalent of the PPRF is the rostral interstitial nucleus of the MLF, which lies in the midbrain near the red nucleus. The lateral portion of the rostral interstitial nucleus MLF is concerned with the up gaze, the medial portion with down gaze. The rostral interstitial nucleus of MLF sends impulses to the nuclei of the third and fourth nerves. The up gaze centers lie more dorsally. Lesions in the region of the posterior commissure may disturb vertical gaze, especially up gaze, Perinaut syndrome. The down gaze center lies more ventrally and lesions there may primarily affect down gaze. Vertical saccades are generated by burst neurons in the rostral interstitial nucleus of MLF with unilateral innervation of the depressor muscles and bilateral innervations of the elevator muscles. Bilateral INC or posterior commissure lesion causes defects of vertical gaze. Another important and fascinating concept is the locked-in syndrome. As I said, midbrain is the center for vertical gaze, pons is the center for horizontal gaze. Suppose if there is a lesion in pons, what happens? It affects the PPRF bilaterally, so the horizontal gaze is affected because pons is restful for horizontal gaze. Both the corticobulbar and corticospinal fibers get affected, so the patient cannot move upper limbs and the lower limbs, but midbrain is intact. So the only movement possible is up and down movements. This is locked-in syndrome. He cannot move eyes horizontally, he cannot use upper limbs and the lower limbs. Only movement possible is up and down movements. This is locked in syndrome. So midbrain is the center for vertical gaze. Pons is the center for horizontal gaze in persons with locked in syndrome. Pons is affected, which damages horizontal gaze. Corticospinal fibers are affected, which cause weakness of all forelimbs. However, midbrain is spared and therefore vertical eye movements are preserved. Bell's phenomenon, very interesting. When you attempt to close the eyelids, the eyeball moves upwards. What is the explanation? It is a reflex upgaze occurs. Reflex upgaze occurs with forced eyelid closure. This is known as Bell's phenomenon. In some conditions, reflex upgaze may be preserved when upgaze is otherwise paralyzed. So what is the mechanism of Bell's phenomenon? It is because of the levator palpebrae superioris, which is responsible for elevation of the eyelid, and superior rectus, which is responsible for the elevation of the eyeball. They are tonically matched. When levator palpebrae superioris is inhibited, when for example looking down gaze, the superior rectus is also inhibited. So when the levator palpebrae superioris is inhibited, they cannot raise eyelid. Eyelid falls down. Superior rectus is also inhibited, so it cannot move eyeball upwards. So eyeball goes downwards. So when you are looking down gaze, looking downwards, both are inhibited. So eyelid also falls down. So and superior rectus also is affected, so it goes downwards. So when you are looking downwards, eyelid closes and eyeball moves downwards, tonically matched. But when you look upwards, they are inversely matched. So when you look upwards, the levator palpebrae superioris is inhibited, so there is a drooping of the eyelid, but superior rectus this time is stimulated, so eyeball moves upwards. So this is the mechanism for Bell's phenomenon. Eyelid falls down, or there is drooping of the eyelid, but eyeball moves upwards because they are tonically matched, but this time inversely. When they look upwards, they are directly matched when they look downwards. So levator palpebrae superioris and superior rectus muscles tone are normally matched. In extreme down gaze, both are maximally inhibited, but in reflex up gaze, the normal parallel innervation becomes reversed. As I said, the medial longital fascicle is responsible for the connection of the 3rd, 4th, 6th with 8th nerves. If not for MLF, we cannot move eyes so coordinately and so perfectly. One side lateral rectus supplied by 6th nerve, the other side medial rectus supplied by the 3rd nerve. Thanks to the MLF, we are able to move eyes in different directions, however way we want to move it. The MLF extends from the midbrain down to the upper thoracic spinal cord. Its primary function is to coordinate lateral gaze by connecting the 6th nerve nucleus on one side with the 3rd and 4th nuclei on the opposite side in order to allow the eyes to move synchronously. Lesions of the MLF disrupt communication between the two nuclei, the 6th and the 3rd, causing internuclear ophthalmoplegia. So internuclear ophthalmoplegia, when the MLF gets affected, the 3rd nerve function gets affected, the medial rectus gets affected, they'll have difficulty in using medial rectus. So there'll be medial rectus being affected, so adduction gets affected. So this is INO, the adduction gets affected. The MLF also has extensive connections and coordinates movements of the two eyes as well as the head and eye and even body movements. Yeah. So now let's see another important concept known as 1 and half syndrome. As I said, medial longital fasciculus goes and connects the medial rectus to the 3rd nerve on one side. So when the medial rectus, when the MLF medial longital fascicula gets affected, it cannot adduct. PPRF, as I said earlier, pulls the eyes towards its side. It causes a gaze, horizontal gaze. So when the PPRF is stimulated, it pulls the eyes to the same side. 6th nerve on the same side, lateral rectus, and medial rectus on the opposite side. But if there's a lesion of MLF and INO, what happens? It results in 1 and half syndrome. 1 and half syndrome is due to combined lesion of the MLF. So half movement gone. Example, if we'll take on the left side, half movement gone. PPRF is gone. So one movement gone. The only movement, half movement is present on the opposite side. That too, there is nystagmus. So 1 and half syndrome, you can see in the diagram, it's due to lesion of combined lesion of the MLF and the PPRF on the same side. Since MLF is getting affected, adduction gets affected, half movement gets affected. Since PPRF gets affected, one movement to the same side get affected. So 1 and half movements are affected. Only half movement is spared. There too, there is nystagmus. So 1 and half syndrome is due to a combined lesion of the MLF and the PPRF on the same side. The patient's only horizontal eye movement is abduction of the eye on the other side. That too, there is nystagmus. Why is there nystagmus? Because of a law known as Herring's law of dual and equal innervation. Yoked muscles get same innervation. So when the medial rectus on one side is not able to move, it sends extra impulse and mightily tries to pull the lateral rectus on the opposite side. It supplies medial rectus on same side and lateral rectus on the opposite side, the supranuclear pathways. And therefore, when the medial rectus gets affected, since they are yoked muscles, the extra impulses, compensatory impulses, goes to the lateral rectus on the opposite side and tries to pull eye mightily onto the other side. So this is known as Herring's law of equal and dual innervation. Because of this, in the yoke muscles, if one muscle gets affected, the other muscle gets extra compensation and extra mightily moves the muscle on the opposite side, producing nystagmus. So one and off syndrome is a combined lesion of MLF and PPRF on the same side. Yeah, these are all the wonderful and fascinating and challenging concepts of supranuclear pathways of eye movements. Very interesting and very fascinating, but challenging too. I hope you have enjoyed listening to my concepts on supranuclear eye movements. I've written most of the concepts of neurology in a book called Focused Neurology, written by me, Sreenivas. It is available online from all leading booksellers, including Amazon. If interested, you can buy this book online. I hope you have enjoyed the discussion on supranuclear eye movements. If you have really enjoyed it, please like it, share it, and do subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my web page, Dr. Sreenivas Concepts. Thank you.